Welcome to Incentives Matter, your guide to what's new in behavioral science and behavioral economics. Let's see what's really driving decisions. Okay, so imagine this. You're a healthcare worker, a doctor or a nurse, someone who understands immunology, someone who sees the devastating effects of infectious diseases firsthand. You'd think getting a flu shot would be a no-brainer, right?
That's the logical assumption, but the data tells a remarkably different story, particularly in places like China. A comprehensive meta-analysis shows that historically, only about 17.7% of healthcare workers there get their annual flu vaccine.
17.7%. That's shockingly low, especially for people who are literally on the front lines of public health. And what's even more counterintuitive, after the global pandemic, you might expect that number to jump to finally reflect the known risks.
Instead, a recent survey in Chengdu, China, taken between late 2023 and early 2024, found the flu vaccine uptake among healthcare workers had plummeted even further, to a dismal 14.1%. This was down from over 31% just a couple of seasons prior. It's a behavioral paradox screaming for an explanation.
So these are the very people generally trusted with public health, the ones who know the science best, and yet the vast majority are opting out of a simple, effective preventative measure. This isn't just about a doctor getting the sniffles, is it?
Far from it. Unvaccinated healthcare workers are significant vectors for transmission. Research has shown that when workforce vaccination rates fall below 60%, hospitals see a statistically significant increase in flu-related illness and even mortality among their vulnerable patient populations. The stakes are incredibly high.
This brings the discussion to a new study protocol being examined, published in the Trials Journal by Wang, Ho, Zhu, and their colleagues. It's a rigorous, two-phase randomized controlled trial aimed at cracking the ceiling, and it's a fascinating deep dive into why these behavioral patterns persist, even among medical professionals.
Exactly. The paper meticulously outlines the friction points and cognitive biases at play here, and they go well beyond what you might call standard anti-vax sentiment.
Listeners might be interested in those. One of the big ones mentioned is the zero price effect and what the researchers call structural friction. What does that mean in this context?
In China, the seasonal flu vaccine is often classified as a Category 2 vaccine. This means it's voluntary, and crucially, it's frequently self-funded. Behavioral economics has extensively documented the immense psychological friction of paying even a trivial out-of-pocket cost. The drop in compliance from a $0 price point to a $1 price point is disproportionately larger than, say, the drop from $1 to $2. So even a small fee can be a huge barrier.
So it's not that they can't afford it, it's the idea of paying for it that creates a wall. And it seems the other biases are familiar territory for behavioral scientists.
Absolutely. One prominent factor is optimism bias. These are medical professionals constantly exposed to pathogens. Many develop a cognitive bias that their immune systems are somehow primed or robust, leading them to underestimate their personal risk of getting the flu or transmitting it. They feel invulnerable.
The irony here is palpable. The people who are literally administering vaccines are falling prey to the exact same cognitive traps, optimism bias, omission bias, and friction, as the general public they serve.
And then there's omission bias, coupled with loss avoidance. Healthcare workers are notoriously overworked. They harbor fears of adverse reactions from the shot, a mild fever, muscle aches. Given their time poverty, the immediate guaranteed loss of potentially missing a shift due to vaccine side effects psychologically outweighs the abstract, probabilistic gain of avoiding the actual flu later in the season. They'd rather omit the action and avoid the certain, though small, discomfort.
It's a classic calculation of certain minor loss versus uncertain larger gain. It's a powerful combination of factors, which suggests that a simple "get your flu shot" message isn't going to cut it. That leads to the first phase of this trial, which is really a masterclass in behavioral experimental design.
Indeed. Wang and colleagues recognize that you can't just throw a single intervention at this problem. Phase 1 of their study addresses the low-hanging fruit using nudges, but with a crucial methodological twist: cluster randomization.
So instead of randomizing individual doctors or nurses to receive a text message, they're randomizing entire community hospitals. Why is that so important for a robust study?
It's about preventing spillover or contamination. Imagine two doctors, Dr. Smith and Dr. Jones, in the same break room. If Dr. Smith gets a text about protecting elderly patients and Dr. Jones gets one about vaccine safety data, they might discuss it. Dr. Jones is now influenced by Dr. Smith's intervention. By randomizing at the hospital level, the researchers ensure that all the healthcare workers within a given hospital receive the same type of nudge or are part of the control group, preserving the integrity of the data. They avoid the break room effect.
That makes perfect sense. It's about isolating the effect of the intervention as cleanly as possible. And within these randomized hospitals, they're testing different types of nudges, right? A standard nudge versus a personalized one.
Precisely. The standard nudge is a generic, one-size-fits-all reminder, like flu shots are available. The personalized nudge is where it gets really interesting. It's dynamically crafted based on a baseline survey of the specific cognitive biases prevalent among the staff at that particular hospital.
So if a hospital staff predominantly expresses concerns about side effects, their personalized nudges will emphasize safety data. If optimism bias is high, the messaging might pivot to social responsibility and patient protection. It's tailoring the message to the specific reason for resistance.
Exactly. And to put this into context, it's worth remembering a landmark mega-study from 2022 by Katie Milkman, Angela Duckworth, and their colleagues. They tested various text message interventions on over 11,000 patients, not healthcare workers, but it provides a benchmark for what a good nudge can achieve.
Ah, yes, the one where they leverage the endowment effect.
That's right. They found that changing the wording from flu shots will be available to a flu shot has been reserved for you increased vaccination rates by 3.3 percentage points, which was an 11% relative increase. And those who received the reserved message were more likely to text back yay to commit. Crucially, those who did text back yay had a massive 78.5% vaccination rate, compared to just 15.6% for those who didn't.
That's a significant boost from a simple rephrasing and a micro-commitment. It shows that nudges certainly work, but the takeaway here, if the analysis is correct, is that even the most effective nudges in that study still left the vast majority of people unvaccinated.
You've hit on the critical point. Nudges are powerful tools for some, the easy compliers, but they have a ceiling. They're not comprehensive solutions for entrenched behavioral resistance. This is what the Wang et al. Paper so brilliantly acknowledges.
And one last methodological detail from this first phase that is particularly robust: how they plan to measure the outcome.
Yes, this is a particularly notable detail. The Wang et al. Protocol explicitly states that the primary outcome will be verified by official vaccination records. This completely bypasses self-reported compliance. Self-reported health behaviors, especially among professionals who know they should be vaccinated, are notoriously plagued by social desirability bias. They might lie to save face. By using official records, the researchers ensure reliable, unbiased data.
So phase 1 sifts out the low-hanging fruit with these carefully designed and measured nudges. But what about the 70 to 80% of healthcare workers who ignore the text messages? Historically, that's often where behavioral scientists might stop and publish their findings.
That's exactly where Wang and colleagues deviate from the typical path. This is the innovative aspect of their study. They don't shrug, they catch the holdouts. In phase 2, the unvaccinated workers from phase 1 are individually randomized into either a motivational interviewing group or a control group.
Motivational interviewing, or MI. For listeners unfamiliar, it's not like giving someone a lecture, is it?
No, it's fundamentally different. MI is an evidence-based, client-centered communication style. It originated in addiction counseling, but has proven highly effective in addressing various forms of health behavior change, including vaccine hesitancy. When a doctor takes a directing style, telling a patient, you need this shot to protect your patients, it often triggers psychological reactance. People dig in their heels.
So MI takes a different approach. It asks, how can we work together to decide?
Precisely. It's about exploring and resolving ambivalence within the individual, drawing out their own reasons for change. It relies on the O-ZARAS framework. O for open-ended questions, like, what are your thoughts on the flu vaccine this year, instead of, will you get the shot? A for affirmations, validating their autonomy, such as, I appreciate you're carefully considering what goes into your body. R for reflective listening, acting as a mirror. It sounds like you're worried the vaccine might make you feel sick and you're too busy to miss a day of work. And S for summarizing, pulling the conversation together so the hesitant individual hears their own ambivalence out loud, which can prompt their intrinsic motivation to change.
It's about guiding them to their own conclusion rather than trying to force one. And this approach has been observed to work in other contexts, right?
Yes, a prominent example is Dr. Arnaud Gagner, who developed the Promovac strategy using MI in maternity wards. His research showed that this non-judgmental, collaborative dialogue significantly increased vaccination intention among parents compared to traditional medical lecturing. It's about empowering the individual's choice, not overriding it.
So you have these intensive one-on-one MI sessions, but there's a crucial logistical element to phase 2 that is particularly notable. It's about removing the final bit of friction.
This is the linchpin. The MI sessions are paired directly with on-site vaccination services. This addresses what behavioral scientists call the intention-action gap, the abyss where good intentions go to die.
Meaning, if an MI session successfully convinces a nurse that getting vaccinated is the right choice, but then they have to go online, book an appointment for next Tuesday, and drive to a different clinic,
They probably won't do it. The friction wins. By putting the needle literally in the exact same room as the conversation, Wang and colleagues reduce the friction of the new behavior to absolute zero. It's the ultimate example of making the desired action as easy as possible.
this sequential approach, starting with nudges and then moving to intensive MI, appears to be a direct response to a trend often discussed on this show.
It's the ultimate antidote to nudge washing.
Nudge washing. For those new to the term, what does that refer to?
Nudge washing is the corporate and governmental tendency to use cheap, scalable behavioral tricks, like changing the default on a form or sending a simple SMS, to claim you're solving a massive systemic issue, thereby sidestepping the harder, more expensive work of structural reform. Wang et al. Explicitly acknowledge that a text message alone won't cure deeply entrenched hesitancy. They respect the limits of soft intervention.
But that brings up the counterargument, and a counterargument might raise questions about the economics. Nudges are incredibly cheap. Sending 10,000 personalized SMS messages costs practically nothing. The marginal cost of the next text is essentially zero.
A fair point. And motivational interviewing, by contrast, is wildly expensive. It requires highly trained personnel, takes anywhere from 15 to 30 minutes per worker, and pulls both the interviewer and the interviewee away from clinical duties.
So is the return on investment, the ROI of MI, really worth it? If a hospital has 1,000 employees and 800 of them refuse the vaccine after the nudges, can the hospital really afford hundreds of hours of one-on-one therapy just to get flu shots in arms?
That's the core tension. And this is where the brilliance of the sequential trial design comes into full view. You don't start with MI for everyone. You start with the cheap nudges.
So the wide end of the funnel.
Exactly. The text messages act as a wide funnel, skimming off the easy compliers, the people who aren't ideologically opposed but might have simply forgotten or experienced minor friction. They get their shot with minimal intervention cost.
And then, only for the remaining, more stubborn holdouts, do you narrow the funnel and deploy your heavy artillery.
Precisely. By the time you get to phase 2, you've filtered out the easy wins. You reserve your expensive, human-intensive intervention, motivational interviewing, only for the individuals who truly need it. It's an optimized resource allocation strategy.
It's elegant. It's basically saying, automate the cheap behavioral prompts for the masses, and only then reserve the expensive, high-touch human interventions for the specific cases that genuinely require it.
This is how corporations and governments should be designing incentive structures for complex behaviors. It's not either or, it's sequential and optimized.
This paper, as previously mentioned, is a protocol. It's the blueprint, not the finished house. The trial is registered as NCT 07157163, and the final data is eagerly awaited. But based on what has been laid out, what should be watched for? What would constitute success?
Two main questions arise. First, the personalization premium. Will the personalized nudges significantly outperform the standard nudges, enough to justify the logistical challenge of conducting baseline psychological surveys across multiple hospitals? A prediction is that the standard, reserved for you type of nudge might prove just as effective as the deeply personalized ones, simply because friction reduction often matters more than message nuance for the easy compliers.
That's a test of whether the extra effort for hyper-personalization truly pays off at the nudge level. And the second question?
The MI conversion rate. What percentage of those phase 1 holdouts, the most stubborn segment, will actually convert after an MI session? Given these are the hardest cases, a prediction would be a modest but clinically significant conversion rate, perhaps in the range of 15 to 20%.
In epidemiology, converting 20% of your most resistant vectors can be the difference between a contained flu season and a full-blown hospital outbreak.
That's a significant impact for a targeted intervention. This isn't just about flu shots in China. This framework has implications for everything from financial compliance to climate change behaviors, all those areas where there is a need to move large populations but encounter pockets of deep resistance.
Absolutely. Listeners are encouraged to bookmark clinicaltrials.gov and search for NCT 07157163. The results of this trial will provide a global blueprint for how to thoughtfully sequence cheap nudges and expensive human interventions. So as the discussion concludes, what are the key insights listeners should take away from this conversation? First, rationality is a myth. Even highly educated healthcare workers suffer from common cognitive biases like optimism bias and omission bias. Medical knowledge does not automatically translate into rational health behaviors. Second, the ceiling of nudges. Text message reminders, even brilliantly worded ones, are effective but limited. They're not comprehensive solutions for systemic behavioral resistance. Third, the sequential funnel is an effective model for behavioral public policy. Use cheap, scalable interventions like nudges to clear the low-hanging fruit, and only then reserve expensive, targeted interventions like motivational interviewing for the stubborn remainder. And finally, friction is king. The best psychological intervention in the world will fail if the action is too hard to take. Pairing MI therapy directly with immediate on-site vaccination access is a critical component of effective behavioral design. This study protocol demonstrates that solving complex behavioral problems requires a layered, pragmatic approach that respects both the power and the limits of different interventions. It definitely provides much to consider. What does it mean for other areas of public health or even other sectors entirely when a cheap nudge hits its limit? And how to effectively identify and then engage those holdouts who need a more tailored human approach. That's all for this episode of Incentives Matter. Join us next time as we keep unpacking what really drives decisions. Thanks for listening. Choose wisely, or at least know why you didn't.